Rapid Fire Biostat Review Part 2. Let's begin. Suppose there's a 65-year-old female and she has significant medical history of obesity, hypertension, hypercholesterolemia, and type 2 diabetes. Now, she is a part of a study where they are testing the effectiveness of new weight loss drug compared to the placebo. And the drug is, of course, randomly assigned to the two groups, and the weight is measured every day for 3 months. At the end of the study, the results between the two groups are compared. Which of the following is the correct null hypothesis? So remember, null hypothesis means the hypothesis of no association. So that would be that there is no relationship or no significant relationship between weight loss as well as the use of the new drug, right? So let's see. The new drug is more effective than placebo? No, that's not the null hypothesis. Placebo is more effective than new drug? No. There is no significant difference in effectiveness between the new drug and placebo? Yes. So remember that null hypothesis states that no difference exists, whereas the alternate hypothesis states that there is some difference that exists. And what do we do at the end of the study? At the end of the study, depending upon where the confidence interval falls, whether the confidence interval has the value of 1 or not, that makes us either accept the null hypothesis or either reject the null hypothesis. And this is quickly summarized over here, that null hypothesis basically is the hypothesis that states that no significant difference exists between the drug and the placebo. Question number 37. Okay, in the previous mentioned study, which of the following would be a type 2 error? Now you must know what is a type 1 error and what is a type 2 error. And if you know the two types of error, then you can easily solve this question. So let's go through this basically in a quick recap. What's a type 1 and type 2 error and how we should remember them, and then we can solve that question. So always remember, I remember it with the help of a mnemonic, that the type 1 error is 1 comes before 2. Since 1 comes before 2, therefore C comes before O. So I always remember that type 1 error is an error with C, commission, and type 2 error is an error with O, that is omission, right? So what do I mean by commission and what do I mean by omission? Just like in some people, they are involved in some crime, right? So sometimes there's a crime of commission, crime or a mistake of commission, and sometimes there is a crime or a mistake of omission. So commission is basically you actually were not supposed to do something, but you actually did it, right? And in the terms of course, our hypothesis, there was no significant association, but you said that there is an association, right? So you committed something, whereas in reality there was nothing existed. You just committed something, falsely accused someone of something. That's an error of commission, also known as type 1 error. And this error can also be called as a false positive error, right? Something wasn't present, something didn't exist, but you falsely said that it exists. This is a false positive error. And another way to put this type 1 error is that you rejected a right null hypothesis, right? So of course, this looks like a bit difficult to memorize, but I remember it with the R's. So the R's go with the C. C is it's an error of commission, and R is that you rejected a right null hypothesis. So the null hypothesis was right, that is there is no association, but you rejected it and you said that there is an association, right? And also remember the keyword no with the first type 1 error. Okay, now coming to the type 2 error, I said that we are going to remember it with the O, omission. So what does omission mean? Omission means something existed and you failed to do it, or you failed to recognize it, or you failed to conclude that there is this thing, right? So that's why the type 2 error is there was a significant association between the drug and the weight loss, but you wrongly concluded that there is no association, right? So it can be remembered with the O, or it can be remembered with the F's, right? So O, F go together, and R and the C's go together. There you were rejecting a right hypothesis, and that was an error of commission. That's type 1. Over here, it's an error of omission with failure to reject a false null hypothesis. So the null hypothesis was basically false, which means that there was a significant association, but you failed to reject it and you said that no, there is actually no association. And another way, again mnemonic that I use to remember it is with now. So NO is for the first error, type 1 error, and W is the type 2 error. NO, no association. W was an association. So type 1 error, there is actually no association, but you said that there is. And type 2 error, there was an association, but you said that there isn't an association. And another way to put type 2 error, it's a false negative error. There was something that existed, but you falsely said that it doesn't exist or is negative, so it's a false negative error. Okay. And what else? Yeah, so if you're given an example and if you're given a question, so from the question you can easily like find out which type of error it is. So if there's wrongly concluded that pill is associated with weight loss, what does that mean? It means actually the pill was not associated with weight loss, right? No association, but you said that there is. This is an error of commission, also known as a type 1 error, also known as a false positive error. Whereas you wrongly concluded that the pill is not associated. What does that mean? It means that it actually is associated with it, actually was associated, we remembered it with the W, it actually was associated with weight loss. So when it was associated but you said that there isn't, this is an error of omission, a false negative or a type 2 error. Okay, so now once you have got the basics of what a type 1 and a type 2 error is, you can easily solve this question, right? On the basis of this, what would be the type 2 error? Type 2 error would be, remember the mnemonic said that it should be that no association exists, but you say that there is an association, or I told you that you can remember it with the C, that it is an error, or it is not an error of omission. Sorry, I'm saying this for the type 1 errors. No, that's incorrect. They say that is a type 2 error. Therefore, this is an error of omission, or there was an association and you said that there is an association, right? So from these examples, which one would be a type 1 error? Let's see. And which one would be a type 2 error? Here they are saying that pill is associated with weight loss and you are wrongly concluding it, which means that actually the pill is not associated with weight loss, but you say that it is. So you are committing to something that doesn't exist, so it is a type 1 error, right? And here you are wrongly concluding in the part B, you are wrongly concluding that the pill is not associated with weight loss, which means that the pill was actually associated with weight loss, but you said that it isn't, so you omitted something that existed. So this is an example of type 2 error. So the answer over here is B. Okay, and I have like quickly summarized it over here, that type 1 is basically an error of commission and 2 is basically an error of omission, the C and an O, right? And I told you that the C basically means that the difference does not exist, and omission, the difference existed but you said that it doesn't exist, but over here the difference did not exist but you said that it does exist, right? Okay, and then I told you that this is also a false positive error, type 1, and type 2 is also a false negative error. And remember, type 1 with R, you rejected a right null hypothesis, whereas for type 2, remember F's, you failed to reject a false null hypothesis. Okay, so failing to reject a wrong null hypothesis, F, false null hypothesis is type 2 error, right? So in case null hypothesis, you already know the null hypothesis is that there is no difference between the treatment and no difference in weight loss between the treatment and the placebo. And rejecting a correct or a right null hypothesis known as type 1 error. Remember the R's, right? Concluding that there is a difference when actually there was no difference. So you did an error of commission, and commission is, or false positive, is basically a type 1 error. Okay, which of the following can be done to decrease the probability of a type 2 error? Now, in order to know that, you must know what does a type 2 error depend on. So type 2 error basically depends upon the sample size. The higher the sample size, the lower the probability of type 2 error. Therefore, the correct answer over here is D, right? So what is beta? The probability of making a type 2 error is known as beta, and this beta is related to power of the study. What is power of the study? 1 minus beta. And then I told you that type 2 error is also known as false negative error. You say that there is a difference, but actually there isn't, right? There is no difference, and you falsely conclude that there is a difference. So when we increase the sample size, so you should know this relationship, that if they say that we are going to increase the sample size of this study, what will be the effect on precision? what will be the effect on the expected effect size, and what will be the effect on the power of the study, and what will be the effect on the beta, right? So the sample size of the study is increasing. Of course, the effectiveness of the study will increase. Therefore, the precision and how close together the values are, that's also going to increase. Precision increased. What about the effect size? Of course, you have large number of people, the effect size will also increase. What about the power? The study will become, of course, more powerful. And what will decrease? The only thing that will decrease is beta. That will decrease. So the probability of making a type 2 error will go down when you increase the sample size, right? So what can decrease the probability of making a type 2 error? We can decrease the probability of making a type 2 error by decreasing the beta. And how do we decrease the beta? By increasing the sample size. Whenever we increase the sample size, what are the effects? We have increased precision, we have increased experiment effect size, we also have increased power. The only thing that goes down is the beta, which is the probability of making a type 2 errors, right? So the probability of making a type 2 error is related to beta, and the beta in turn is related to power of the study. And what is power of the study? Power of the study is 1 minus beta. Okay, question number 39. Now you have a patient who has been checking his blood sugar levels. Mostly the blood sugar levels are around 120 milligrams per deciliter. So that's like sort of the mean, or you can say the center or the peak, right? But one time on admission, his blood sugar levels go to 526 milligrams per deciliter, which means that something has positively skewed our data. There is one outlier, a value which is not in our average range and is very different from the average in either towards the positive side or towards the negative side. Or here it's on the higher side, so it's a positive skewing outlier, right? And they can ask you that what will be the effect on these three: mean, median, mode. So basically what you have to know is that out of mean, median, mode, which will be the most effective and will most deviate towards this value of 526 milligrams per deciliter, which is our outlier. Which value will be deflected the most towards it, which will be deflected medium in a medium way, and which will be deflected in a minimum way, right? So remember this. I basically remember it with the alphabetical order, right? The alphabets or English alphabets. EA comes before ED, and ED comes before OD. Of course, like O comes very later, right? And E with the A comes at the top, then E with the D comes after it, and O with the D comes after it, right? And you can also remember it that median, of course, will always remain in the middle, right? So median remains in the middle. It's not skewed drastically, and it's not skewed very less, right? Whereas mean is the value which is skewed the most. And of course, you know, mean is the value in which we take the sum of all the values and then we divide it by whatever number of values, n number of values, right? Maybe 5, maybe 6, maybe 10, right? So because it depends upon the sum of values, any one skewed value is going to skew it the most on that side, right? So if they ask you which value is the most affected by an outlier, or they give you such an example that the one blood sugar reading of 526, which value is the most effective and will most lean towards 526, that is, it will become the greatest, then mean will become the greatest. So from this, we have to choose the equation where the mean is the maximum, not the lowest, but the mean is the maximum, right? Then we have to keep the median in the middle. I told you the median is the value that's already the middle value, right? So middle value will be affected by this one outlier, but will be affected moderately, right? And as for the mode is just the most frequent value. So it's quite possible that the most frequent value over here is 125. It appears 3 times, right? So if 125 appears 3 times and there is one value of 526, mode will not even care. Mode stays the same, right? Because it's the most frequent value. So mode is the one which is affected the least, although it is the most frequent value, but it is affected the least in case of an outlier, right? But and suppose like there was an opposite situation in which they actually gave you that now there is one reading in which he has 60 milligrams per deciliter, and now what will be the order? Now, which value will become the smallest? So it's becoming affected, but it's going to the smaller side and becoming the smallest. Again, mean skewed the most. Okay, let's give it 3 arrows. Median skewed mediumly, so let's give it 2 arrows, and mode, which is skewed the least, so let's give it 1 arrow. Okay, but in this case, can you see that the higher or the lower, the order has changed? In this situation, the mean has become the smallest because our outlier is on the smaller side. This data is negatively skewed, whereas in the case of 526, our mean had become the greatest, right? And why it had become the greatest? Because the value was positive. positively skewed. So in both these situations, you should know what will be affected the most, that's mean, what's affected the least, that is mode, and what is affected in a medium fashion, that is known as the median. And that's exactly explained over here, that a value that differs significantly from the usual measures is known as an outlier, and that affects the measures of central tendency. What are the measures of central tendency? Mean, median, and mode. Which is affected the most? You already know it, mean. Which is affected the least? You already know it, the mod is affected the least, right? No, not the least. They are saying the lesser or the medium. That's median, right? Why? And you know the reason. That mean is affected because it's the sum of all the values. So if one value is skewed, so mean is going to be skewed the most. Whereas median is it's dependent upon, of course, like the middle two values. So it's going to be affected a little bit. But what about the mod? Mod is affected the least because it is the most frequently measured value. And here is a quick review of these three things that we just learned, that if the data is skewed positively like 526, mean will be affected the most, median will be in the middle, and mod will be affected the least, right? So, and median is the lesser value affected. Whereas if we had one value in the opposite direction, suppose 60, then in this situation everything would actually become opposite. Then instead of mean become the greatest, mean would become the smallest, and then median would be greater than it, and mod would be greater than it, and that would be a negatively skewed data. Okay. Question number 40. There's a public health department. It is working on developing a program to decrease both the incidence and prevalence of lung cancer. Which of the following intervention would best achieve the goal? So now we want to decrease the prevalence, which means the number of existing cases, right? And suppose you don't know the answer, you have no idea how to decrease the prevalence of lung cancer. You can just compare all the 5 examples and just like find something that's the odd one out, right? Or we have another way in which like we can see that, okay, we can go one by one and see which one decreases the prevalence, right? If we develop new chemotherapeutic agents, the people will be cured, and of course, this will lead to decrease in the prevalence. Oh, we want something that decreases both the incidence and prevalence, right? So new chemotherapies are just the treatment. They will not decrease the incidence, they will only decrease the prevalence. If we improve specialist referral times, of course, that's also going to just decrease the prevalence because you're going to refer a patient after he has been diagnosed, right? But if you introduce a smoking cessation program, that is a preventive measure, and a preventive measure is going to decrease both the incidence and the prevalence. Therefore, smoking cessation is the correct answer, which is C. Why? Because it will decrease both the incidence and prevalence. And the other things, let's look at the screening program as well. Of course, like screening program will not do anything to the incidence. It will just like catch the cases earlier. So maybe it catches them earlier, so the people are like diagnosed earlier and then they are treated earlier. So maybe it decreases the prevalence but will not do anything to the incidence. And similarly, you increase the number of surgeons. Yeah, you can increase the number of surgeons to whatever. They will just cure the disease and just decrease the prevalence, but they cannot do anything to the incidence. So if you want to decrease both the incidence and the prevalence, remember you have to work on some preventive factor. If the preventive factor can be addressed, it means both the incidence and the prevalence would be decreased. Whereas if you just want to decrease the prevalence with the incidence remaining the same, so incidence is remaining the same, then you need to work on some therapeutic agent or some treatment. That is such as surgeons, referral times, or the chemotherapeutic agents or something like that, right? So that is basically going to decrease the prevalence of the disease, right? So if a risk factor, just a quick review, if a risk factor of let's say smoking is eliminated, what will happen? There will be both a decrease in the incidence as well as the decrease in the prevalence, right? Whereas all the other examples like chemotherapeutic agents or some surgeons or screening programs or referral times will actually not change the incidence, right? Because the disease is still occurring in the same way. It's just that the patient's survival will increase and therefore the prevalence of the disease in the community would actually increase. And here I have summed it up that if you want to decrease the incidence and prevalence, we have to work on something that is a risk factor such as that of smoking. But if we just want to decrease the prevalence and we don't want any change in the incidence, then we can work on some like treatment option and anything that improves the patient's survival, which includes the number of surgeons or the earlier referral times or some sort of screening or some sort of chemo agents, right? So these are all going to just affect the prevalence and will not affect the incidence. 41. A study has been done to assess the strength of association between smoking and coronary disease development. At the beginning, the patients are divided into two groups based on whether they smoke cigarettes on a daily basis, and then they are followed for 10 years development of any form of coronary heart disease. At the end of the study period, it does not appear to be any significant difference in the coronary disease incidence between the two groups. Which of the following is the most likely explanation of these findings? So, why did this happen? Like, you have to know, you already know that, of course, like smoking and coronary artery disease, the relationship between them, the two of them, is actually established. But why did this happen, that we followed these smokers, right, and those who were non-smokers over 10 years periods of time, but now there is no significant relationship? So one thing that should come in your mind, okay, these were smokers and they were actually monitored. So because they were monitored, it's possible, like if someone is monitored, of course it's possible they change their dietary habits, if they have to log whatever they eat daily or how much they exercise daily. So it's possible if their smoking was being recorded, then they actually decreased how much they were smoking. Therefore, smoking is not a risk factor for coronary disease. That's wrong. Smoking is a risk factor. But what is something that we can say that if a person is being observed, they change their actions, that is known as the Hawthorne effect. So the correct answer over here is E. The behavioral change in participants who know that they are being followed is known as Hawthorne effects, right? So the patients who were followed, they either stopped smoking or they decreased the amount that they smoke. Whereas the researchers strongly believe that there is no association, or they believe that there is an association and their thinking affects the results of the study. This is known as observer bias. And if there are people who are who actually have developed a disease, then they over-report the exposure to a risk factor. For example, the patients who have hepatocellular carcinoma and they report that they were actually heavy alcoholics, then they remember it better than those who are controls. This is known as recall bias. Tendency of the hospitalized patients. So the keyword over is hospitalized. Whenever we have hospitalized patients and we try to compare them to healthy patients, healthy people, then the type of bias in this situation would be Bergson bias, because the hospitalized patients tend to be less healthy and they have more comorbidity as compared to the normal population. So this is what we have done over here, that if the smokers are followed for coronary artery disease and no association is found, why? What could be the reason? Hawthorne effect. The patients who are being observed, and therefore they either decreased how much they were smoking or they quit smoking altogether. Question number 42. A group of researchers is conducting a study to compare a new anti-diabetic drug with metformin. They are taking a total of 500 patients. 300 patients receive the new drug and 200 patients are receiving metformin, which we are considering over here as the control or the gold standard. And then both the patients were, a group of patients were actually followed for 3 months. At the end of 3 months, our results are average fasting blood glucose level in the group treated with metformin is 135, and those which were treated in the new drug is 133.9, with the p-value being 0.03. What is the interpretation? Now, in the interpretation, they want us to be able to identify two things: statistical significance and clinical significance, right? And the two are two different things. So first of all, let's see what is statistical significance. Anytime our result is has p-value of less than 0.05, then we call it that the result is statistically significant. When we take the maths and the statistics into consideration, yes, this new drug is very effective. But what is meant by clinical significance? Clinical significance is when we see a drastic change as compared to the gold standard or the control. So here the control was changing the blood sugar levels, bringing the blood sugar levels down to 135.5, right? And what's the new drug doing? It's like barely 133.9 is roughly 134. So how much of a difference do we have between the values of 135.5 and 134? They're almost the same, right? So we will say that although the drug is statistically significant, the results are not clinically significant, right? So the correct answer over here is A. They are clinically insignificant. There is no significant difference clinically between 134 and 135.5. But yeah, speaking statistically, P is less than 0.05. So they are statistically significant. So here's a recap. Anytime the P value is less than 0.05, that basically means that the new drug is having results which are statistically significant, right? But the actual clinical value of actually decreasing some values from 135.5 to 133.9 is actually not clinically significant, right? So it's unlikely to be significant. So, okay, we missed this in the previous question, that if the observer is strongly convinced of something, that's known as observer bias. If the patients who have the condition, they over-report the exposure as compared to the controls, this is known as recall bias. The hospitalized patients tending to be less healthy as compared to the general population is known as Bergson bias. And if we have blood glucose with metformin 135.5 or with a new drug to be 133.9 with a p-value of 0.03, then its clinical significance no, but the statistical significance is yes, as the p is less than 0.05. Question number 43. A large study is done to assess the average blood glucose values between patients with different chronic conditions, and the groups are basically based on their underlying comorbidity, and the blood sugar measurements are taken. Now, what we want to do is, that's the key word over here, we want to compare the mean blood glucose levels. And how many conditions are there? They are saying different chronic conditions, so we don't know, might be two, like maybe must be more than two, or else they would have said that like two chronic conditions, right? But there they didn't say, they said different chronic conditions. And now we have to compare the mean. So which is the statistical test? Always remember that t-test is the test which is used to compare the mean blood glucose levels, provided that the number of groups are 2. And ANOVA is the test which is for groups which are greater than 2, or you can say equal to 3 and greater. So that is the test is known as ANOVA, and over here the correct answer would be ANOVA. So the test used to compare the mean between two groups, right, between greater than two groups, is known as ANOVA. And mean basically means there's a range of values. So when we were measuring blood glucose is not, it's not going to come like yes or no, right? And we weren't measuring blood glucose like yes high blood glucose or no high blood glucose. We were actually measuring the values of blood glucose. So it could be something like 90, 100, 110, right? So that's a range, and this data is not categorical like yes or no. It's a sort of a numerical data, right? So whenever we have to compare the mean of this numerical data or a range of values for greater than two groups, that's ANOVA. But if we have to compare the same thing, compare the mean of just two groups, if they said that there are just two chronic conditions like hypertension and suppose RA, right, then it would be t-test. Whereas if you want to check the differences between categorical outcomes, like suppose instead of measuring the glucose in the form of 90, 110, they just said that okay, we are going to measure it like diabetic, non-diabetic, and then we are going to compare it either in different chronic conditions, or we are just going to compare RA and SLE, right? So if they were to just consider two groups and then they had a categorical outcome. What is a categorical outcome? Yes or no outcome, diabetes or no diabetes. Then to check the difference between categorical outcomes, if we just had two diseases such as RA and SLE, that would be the Fisher's exact test. But if we have more than three, then that would be known as the chi-square test, right? And whenever data is gathered from large number of previous studies and then it is analyzed to get more precise results, that is known as a meta-analysis. And a quick review, if we are going to compare the means but those of greater than two groups, then the test will be known as ANOVA. If we are again going to compare the means but just of two groups, this is known as t-test. If we are going to find the differences between categorical outcomes, again between just two, that's known as Fisher's extract. But if it's greater than two, that is known as chi-square. And also remember it with this mnemonic that 2 is exactly 2. Therefore, the name is Fisher's exact, right? And for greater than 2, of course, it's chi-square. And T is just like a shorter name as compared to ANOVA. So t-test is just for the two groups and ANOVA is for greater than two groups. Okay. Question number 44. If the researchers now wanted to compare, now there's another similar question, they compare the blood glucose levels of any chronic condition and only used two groups, right? They're just taking one chronic condition like hypertension, right? And the groups are just now healthy and not healthy, but they're still comparing blood glucose levels, which means you still have a range, like numerical range, like 90, 100, 110. It's not categorical like yes or no, diabetes, no diabetes, right? So the test that would be most appropriate for these two groups would be the t-test. T for 2 and T is smaller than ANOVA. So for comparison of the mean of two groups, t-test. Comparing the mean greater than two groups, ANOVA. Check the differences among categorical outcomes in just two groups, Fisher's extract. Check the difference between categorical outcomes in greater than two groups, chi-square test. Data is gathered from large number of previous studies and statistically analyzed to get more precise results is known as meta-analysis. Okay. Question number 45. A study was done where we have to determine the incidence and outcome of myocardial infarction in a large urban area. The annual incidence was 600 per 100,000 people, and the case fatality rate was 15%. Which of the following represents the annual mortality from MI? So, how this is the question? How do we calculate the annual mortality rate when the incidence is given and the case fatality rate is given? So, incidence means the number of new cases, and case fatality rate means how many people actually die from it, right? So, simply calculating the annual mortality rate can be calculated by multiplying the incidence with the case fatality rate. We take 600 upon 100,000 and we multiply it by 15%. So 15% is 15 divided by 100. We simplify the values and the answer is 90 divided by 100,000. So just know this formula, that annual mortality rate is equal to incidence multiplied by annual mortality rate can be calculated by multiplying the incidence with the case fatality rate. 46. A resident is pre-rounding the 7 patients under his watch. As part of this checkup, he measures the heart rates. He measures the following values per minute. What is the mean? You already know that mean is the average. We are going to line up all these values in an ascending order, and then we are going to divide it by the total number of values. What is the total number of values? 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 7, and then we are going to add up all the values divided by 7, and the mean is then going to come out to be 87, right? So 83 is basically the mod or the most frequent value, right? But the mean is actually 87, and if they ask you for the median, then you should be able to calculate the median as well, the value that is in the middle. I told you there are 7 number of values. If you arrange them in ascending order, there are 3 values at the bottom and 3 values at the top. So this value in the middle, 86, is the median because it is in the middle, right? So you can calculate, if you are given a set of data, you can easily calculate the mean from it, and the mean over here was C, 87, and because it actually came down to 86.7, so it can be rounded off to 87. The mod over here, the most frequent value that appears 2 times, is 83, and the median, which is like the having equal number of values above and below it, is basically 86 because there were 7 number of values. So we have already done it, that the median, the most frequently occurring heart rate, is B, 83. Okay. Do we have to revise anything from here? No. Okay. We have a new ACE inhibitor, and that has been developed for slowing the progression of advanced diabetic nephropathy over 5 years. And the rates of end-stage renal group in the group that was treated with the new drug is 0.03. So as soon as you see this rates of ESRD new drug, immediately label it as our treatment, the rates in the new treatment group. And the odds of ESRD development with ramipril, which is of course the control or the gold standard over here, would be the RCO. And we have to now calculate the relative risk reduction, right? Remember, relative risk reduction, it has 3 R's. Therefore, in the formula, we will have 3 R's. R control minus R treatment divided by the R control. We'll plug in the values over here. 0.12 minus 0.03 divided by 0.12, and the answer will come out to be 75%. So the answer can be 0.75, and 0.75 can also be called as 75%. So there is a 75% risk reduction with the new drug as compared to ramipril, right? So you need to know the formula for relative risk reduction is R control minus R treatment divided by R control. There's a large cohort study that was done for the relationship between smoking and pancreatic cancer development. Patients were divided into smokers and non-smokers. They were followed with 10 years for pancreatic cancer, and at the end of the study, the relative risk was calculated. And which of the following confidence intervals most likely suggest that smoking significantly increases the risk of pancreatic risk development? So we have to find one confidence interval which says that the results are statistically significant. So for the results to be statistically significant, from a previous question we already saw that they should not have the value of 1 in it. So any of these ranges which has the value of 1 in it will become statistically insignificant. So let's find out, right? 0.3 to 1.8. Okay, that is statistically significant, but this is less than 1. So whenever the value of confidence interval is actually less than 1, it means this statistically significantly decreases the risk, right? So no, that's no. 0.5 to 1.51 has the value of 1, excluded. 0.1 to 3.6 excluded, 0.9 to 2.5 excluded. The only value that increases the risk and does not have the value of 1 and is actually greater than 1 is 1.5 to 1.8. So in order for the results to be statistically significant, what should the confidence interval not contain? It should not contain the relative risk value of 1. If relative risk value of 1, it means that there is equal risk of developing the condition between both the groups, right? As long as relative risk is less than 1, that means that this thing is protective, it decreases the risk. If the relative risk is greater than 1, it means it's a risk factor and it increases the risk. So the only correct answer over here is 1.5 and 1.8 because it does not contain the value of 1 in it, and it is also greater than 1, which means that it is possibly a risk factor, right? And the other question is also related to it. Which of the confidence interval is going to tell us that the smoking is protective? Again, the range should not have the value of 1 and it should be less than 1, right? So the only range that doesn't have the value of 1 and is less than 1, as we discussed, is A, 0.3 to 1.8, 0.3 to 0.8, which tells us that smoking is actually protective against pancreatic cancer. So quick recap: relative risk reduction is risk control minus risk treatment divided by risk control. Confidence interval that is statistically significant should not contain the value of 1, relative risk 1, right? And if it does have the relative risk of 1 in the confidence interval, it basically means that there is equal risk of development of the condition in both of the groups, right? And if the relative risk is less than 1, it's protective. If relative risk is greater than 1, it is a definitive risk factor and it actually increases the risk, whereas protection means it decreases the risk. Okay, let's move on. A clinical trial is done to assess the effectiveness of a new statin drug, right? And the people are divided into two groups. One of the two groups is treated with the new drug for 3 months, while the other is treated with atorvastatin. Neither of the participants nor the researcher knows who is getting the drug. Such approach best prevents which of the following? So did we actually do? What was the approach? Then no one knows who is getting the drug, which basically is blinding. So what does blinding basically do? Blinding actually takes out the observer bias, that if the researchers know that which group is taking the new drug, automatically they might expect that, okay, these people are taking the new drug, therefore they might have this result. But if they don't know who's taking the new drug, they can't predict it, and therefore observer bias is the bias that is prevented by blinding. So blinding in clinical trial prevents observer bias. If the researchers are aware, of course, like their knowledge may influence it skew the data. So this is known as observer bias. And when does recall bias happen? It happens in case control studies, because the people who have already developed the disease, they tend to over-report the exposure. Whenever there's a bias in the selection of the participants, this is known as selection bias. And whenever there's a tendency of the screening test to detect diseases that have longer latency periods, this is known as length time bias. Whenever there's an external factor that affects both the variables, that is, it affects the risk factor and they affect both and leads to incorrect interpretation of the results, this is known as a confounder. And let's do a quick recap. If no one knows who is getting the placebo versus the drug of treatment, then the bias prevented is the observer bias, and this process is known as blinding. So basically blinding prevents the observer bias. Okay, and recall bias is like in the administration of questionnaires, and length time bias is in chronic diseases that have long latency period and then they are over detected by the screening tests. Question 52. A large clinical institute has developed a new drug for the management of advanced melanoma. The early results show that the average survival time increased by 2 years. And for the most part, serious side effects were not observed. No participants died from the complications. If treatment was administered to everyone with advanced melanoma, which of the following best describes the effect? So what is the effect? And they've already given in the question that the average survival time is increasing. So what will happen to the incidence and the prevalence? The first thing is that this is a drug that is causing treatment, right? So because this is treating the people, therefore there will be no effect on the incidence, right? But once it's treating the people, their lifespan is increasing by 2 years, which means that the prevalence, the number of people who are still living with the disease, is actually going to increase? Are they like completely treated or no? No, they are just saying that the average survival time is increased, right? So the correct answer over here is D, that the incidence does not change, but the prevalence is increasing because the people are like surviving, but it's possible like they still have the disease. It's not like they were totally cured, right? Okay, so finding a new treatment that improves survival, what does that do to the incidence and the prevalence? It will increase the prevalence of the disease, and prevalence is basically how many people are affected in by that particular condition, right? Whereas if the people were mostly to die within a year from the same time they were diagnosed, then of course prevalence incidence would remain the same. The people have actually, like the people who developed the new disease have actually died now, right? But now since they are living longer, therefore that means that the prevalence will increase, but the incidence will not change, right? And how can we change the incidence? That's a good question. A way to change the incidence of the condition is by changing the risk factor exposure. For example, in the case of melanoma, if you change the amount of time that the people are spending in the sun, or they start using sunscreens, then that is a protective factor, and that will decrease both the incidence and the prevalence. So a quick review: a drug that increases survival time by 2 years, its effect on the incidence will be no change. The effect on the prevalence would be increased. How do we change the incidence? We change the risk factors such as people quitting smoking or decrease sun exposure. That is going to decrease the incidence and ultimately the decrease in prevalence. Question number 53. There's a 60-year-old male and his brother was diagnosed with colorectal cancer, and the patient undergoes screening colonoscopy and that comes back negative, and he is concerned about the possibility of missing a tumor on a colonoscopy. And while helping the patient understand the results, which of the following tests should the physician most refer to? So we have to remember that the patient's test actually came back how? Negative, right? And he is fearing that he has some sort of tumor might have been missed. So we are not starting with the patient being healthy or diseased, right? We are not starting with a healthy or diseased patient, because in that situation we would discuss sensitivity and specificity, and we would say, okay, what's the likelihood of this patient having a positive disease, or what's the likelihood of positive test result, or what's the likelihood of this patient having a negative test result. But over here we're starting with a negative test result, and now we want to know, okay, what are the chances that the negative test result patient is actually diseased, or the negative test result patient is actually healthy and doesn't have the disease. So this is known as the negative predictive value, and we are concerned with E, the NPV. Why? I told you that for NPV and PPV we actually begin with the test. So the test has come back negative, right? And now we are like, how probable it is that the person is actually negative for the disease. This is negative predictive value. Whereas if the test actually came back positive, right, and then after the positive test we were to find out, okay, what's the probability that this person actually has the disease. This is known as positive predictive value. And of course, like the higher negative predictive value, because the patient is indeed healthy, he doesn't have any other condition, so it depends upon the prevalence, right? So there's like the patient is healthy, so the negative predictive value is also less, right? And the percentage of people who actually have the condition or don't have the condition, and then we follow them, that whether their test result will be positive or negative, that is known as sensitivity and specificity. And when the results are closer to one another, that is known as a precise test. So to review, patient concerned about colonoscopy not missing cancer, and he has basically tested negative. And what are we going to discuss with him? Negative predictive value, which is basically the patient has tested negative, and now what are the likelihood that he's really negative. So patient is indeed healthy, so negative predictive value is very high for this situation. It's just this person, right? Whereas if the patient has tested positive and he was concerned that it is truly positive, oh, it's possible that I might be healthy, then we would discuss the positive predictive value with that patient. Question number 54. The new definition of hypercholesterolemia has changed and a cutoff value has decreased by 10 milligrams per deciliter. What would be the effect of such a change on the incidence and prevalence of hypercholesterolemia? So we have decreased the value from 250 to 240. Before this, the people who had blood cholesterol levels greater than 250, of course not less than 250 will be diagnosed with hypercholesterolemia. People who are greater than 250 were diagnosed, right? But in this situation, if we look at both these numbers, the people with greater than 240 are going to be diagnosed, which means that the people who are between 240 and 250 will also now be counted as having hypercholesterolemia, which means that the incidence in this situation will increase. We will diagnose more cases of hypercholesterolemia and prevalence would also increase. So the correct answer over here is B, that if we decrease the cutoff value when the test comes positive at like a greater value, then both the incidence, that is the new cases, as well as the prevalence, that is the number of patients that exist, is actually going to go up. If we decrease the value for a particular disease, which like of course we call positive by any value that is greater than that cutoff value, then both the incidence and the prevalence would actually increase. A group of researchers are developing a new drug for the treatment of AML, and molecule has been tested on 10 healthy volunteers. So there are no disease patients, they're just healthy volunteers. Then the phase of clinical trial would be, the correct answer is A, phase 1. So if they ask you that there are small number of healthy volunteers, that is phase 1. If they give you that we are assessing the safety, toxicity profile, pharmacokinetics, or pharmacodynamics, which phase were they tested on? I remember it with mnemonic STOP. So we stop it in the first phase, right? So safety, toxicity, pharmacokinetics, and pharmacodynamics with a P square, right? That's going to be tested in phase 1. But what if they say that we are testing a moderate number of patients and we are finding out the drug efficacy, its dosing, and side effect? I call it EDS, right? So like squamous eddies in like squamous cell carcinoma, no, not squamous cell carcinoma, some other disease, but eddies from eddies, you can remember EDS. And with the EDS, efficacy, dosing, and side effects on a moderate number of patients would be phase 2. Whereas when they tell you that we are comparing this drug and randomly assigning this treatment and the placebo, or we are using a gold standard and we are comparing the outcomes of the placebo to the current standard of care, the new drug to the placebo or standard of care, then this is known as phase 3. And if they say we are doing marketing surveillance and looking for rare or long-term adverse effects, then this is phase number 4. So a quick recap: tell healthy volunteers given a disease drug for safety, the stop that we have found out, safety, toxicity, pharmacokinetics, and pharmacodynamics, is known as phase 1. Small number of healthy people, right? Then next we have moderate patients to assess the efficacy, dosing, and the side effects, EDS, phase 2. Large number of patients, but now we are comparing the new drug to the placebo or the standard treatment, then this is known as phase 3. Right? And we are also going to like assess the safety and efficacy. Once we are doing the post-marketing surveillance, looking for rare side effects or long-term side effects or black box warnings, right? Then this is known as the phase 4. Which of the following best describes what is being assessed in the previous question? So the previous question was about, remember, phase 1, 10 healthy volunteers. What are we assessing? Long-term effects of the drug? No, that was in phase 4. Rare side effects? No, that was in post-marketing surveillance phase 4. Pharmacokinetics? Yes, it was part of our stop mnemonic. So safety, toxicity profile, pharmacokinetics, and pharmacodynamics. Yes, they were in phase 1. So the correct answer is C. Optimal dosing, EDS. It was in phase 2. Comparison with the current standard of care, phase 3, right? So the correct answer over here is C. It has been determined that the drug is safe. Which of the following is most likely next step for the researcher? So they have done it on 10 healthy volunteers. So now we are going to give it to a moderate number of patients who have actually been diagnosed, but we are still not going to compare it. The next step would be, so this would be phase 2, this is phase 1. Next would be, we will compare it to either the placebo or the current standard of care. If there is a current standard of care, well and good, otherwise the placebo. And then the fourth would be like, we are going to release and then do the post-marketing surveillance, right? Okay. Following Raj clinical trial, the drug has now been released to the market. It proves that it induces the remission in a significant number of patients. But there is another thing. There is increased number of case reports of seizure development. So what's the appropriate response to it? We are going to withdraw the drug from the market. The correct answer is A. This is known as post-marketing surveillance on phase 4, in which we look for less common and long-term side effects or black box warnings, and this can lead to withdrawal of the drug from the market until further analysis is done. So we have already done all of these, so I don't think we have anything to review. Okay, drug as associated with seizures. So next big step would be to withdraw the drug from the market. A study is done to assess the effectiveness of a new pain medication of chronic pain. And there's a total of 100 patients. They are assigned either the new drug or the additional treatment. And we do a survey 7 days later and ask them about their pain levels. So there's a statistically significant improvement in the pain levels as seen with the patients on the new drug. Which is the following is the limitation of the validity of the study. Okay, let's go by one. Low number of patients, no, 100 is a good number. Recall bias, okay, it's not like they had to recall something from their past and remember some past pain, right? So no recall bias. They are telling the pain levels right now, right? Recruiting patients from the clinic only. That could be something positive, possible, yes, that they are not recruiting the patients from other places. And then there is the lack of binding, right? So they did not blind the patients, and they knew that they were receiving the new drug or they were receiving the additional treatment. So some people were taken or they were taking no additional treatment, right? So the people they were taking a new drug, they knew of course that they are taking a new drug. If they had given a placebo to the other group of people, then both would be like, okay, we don't know. Both would think that, oh, we are getting a new drug. But in this situation, some people know they are getting a new drug and some people know that they are not getting a new drug. So the correct answer is D, lack of blinding. So blinding refers to the unawareness of the study participants, right? Whether they are receiving the treatment or not. But here they were not blinded, right? So because they were not blinded, there is a chance that they can develop a bias, right? Okay. Because the people who actually were given the treatment, they'll think, oh yeah, our pain levels are better. But those who were not given additional treatment would say that no, our pain is not better, right? And the tendency of the patients to over-report the exposure is known as recall bias. And of course, pain levels are subjective. We are comparing the subjective levels in both the groups, right? So patients are randomly assigned. They have to record the pain levels. What will decrease the validity? The placebo effect, right? Because there is lack of blinding, the patients know who is getting the drug and who's not getting the drug. So this lack of blinding is actually going to make this study statistically insignificant. 60. A researcher is working to determine the strength of association between smoking and bladder cancer development. He decided to do a retrospective cohort study, and he has identified the appropriate study participants. At the end of the study, he calculates the relative risk and the confidence interval. Relative risk is 2.2. Which of the following p-value would suggest that the result is significant? Remember, for a result to be statistically significant, the p-value should be less than 0.05. Therefore, the correct answer over here is A. That's the only value less than 0.05, right? Okay, so if the p-value is less than 0.05 for a study outcome, this means that there is less than 5% chance that the result was due to chance alone. So it means that 95% chances are this was actually the reason, right? There was a statistically significant association and the chance of making an error is just 5%, right? So generally the p-value is 0.05, and over here the only value less than 0.05 is actually 0.04. So for a study to be statistically significant, the p-value should actually be less than 0.05. So less than 0.05 p-value basically means that there is a 5% chance that the results that were observed in the study were due to chance alone. Okay. Question number 61. A case control study has been conducted to assess the relationship between excessive alcohol use and liver cancer development. Okay, so we have two things. We have an exposure, that's alcohol use, and we have a disease that is liver cancer. So E and D. Remember, D at the top, E at the bottom. E at the bottom, E or the risk factor. We can also call it the risk factor. 100 patients with liver cancer, 100 patients matched in controls were identified. Okay, let's put the 100 at the bottom. Disease, positive, negative. Let's make it like this, table like this. Let's put the disease at the top, positive, negative. Risk factor at the left, positive, negative. And then let's plug in the values, total 100, 100 are both, right? Okay. Of the 100 controls, so controls are those who are non-diseased, right? 15 were found to be using excessive amounts of alcohol. So of these, there are of the people who are controls, 15 were actually exposed to the risk factors. So we're going to put the 15 at the top, right? And 40, oh, of the 100 patients, 40 were found to have excessive amounts of alcohol. So 40 were found to have positive risk factor, and they were positive for the disease as well. So simply subtracting, like 100 minus 40 is 60 and 100 minus 15 is 85, right? And which is the appropriate first step? You know that this is a case control study, and from the mnemonic from case control study, you know that CCDO, right? Captain Carl was doctor of osteopathy, right? Therefore, we have to calculate in this situation the odds ratio, and odds ratio is calculated by taking the odd values. Which are the odd values? We take A divided by B, and then we divide it by C divided by D. So the odds ratio can here be calculated as 40 upon 60 divided by 15 upon 85. And then we can rearrange the entire values over here, like 40 upon 60 divided by 15 upon 85. Rearranging it, we have 40 divided by 60 and 85 divided by 15. So, and of course, this is how we have calculated it, but the correct answer over here is just we have to tell that for a case control study, the value that we have to calculate first is the odds ratio, right? And they can, of course, they can totally omit the words odd ratio, and they can just say that the ratio or odds of exposure among the cases to the odds of exposure among the controls is known as odds ratio. Whereas the risk of developing disease in both the exposed and the unexposed, so we have groups that have the risk factor, and then the risk of developing disease is the cohort study. In the cohort study is known as a relative risk. Whereas if we find the difference in risk between the exposed and the unexposed, that is known as attributable risk, and the number of patients who need to be exposed to a specific risk factor to be harmed is known as number needed to harm, and it is 1 upon absolute risk reduction. And then the number of new cases to the total number of people at risk is known as the incidence. So here we have again a quick review. Case control, in case control the mnemonic is CCDO. So therefore we begin with the disease, and then we follow for the risk factors, and we put the positive negative disease at the top, exposure positive negative at the left, A upon B, C upon D. So odds ratio is calculated A divided by B further divided by C upon D. Whereas for cohort, remember our cohort, we begin with the risk factor, and then we go to the disease, and we calculate the relative risk, and relative risk is A upon A plus B divided by C upon C plus D, and attributable risk is just the difference between the risk in the exposed minus the risk in the unexposed. Okay, question number 62. Which of the following is the correct way of calculating the odds ratio? We have already calculated the odds ratio from the previous one, and we can just go and see where did we calculate it. 40 into 85, 60 into 15. Is there any value like this? 40 into 85 divided by 60 into 15. So the correct answer is D. We have already calculated odds ratio. Which of the following biases needs to be addressed in this study? So we were doing what sort of study? Case control study, right, in which the people have already developed the disease. So remember, the people who have already developed the disease, they are more likely to over-report the exposure or the risk factor. Therefore, the bias over here would be the E, recall bias. That in retrospective studies, the patients who tend to over-report their alcohol use, this is known as the recall bias. Whereas, if we have a screening test, and the screening test just makes us believe that the patients are being diagnosed early, and then there is increased survival without improvement in the patient outcomes, this is known as lead time bias. And then the tendency of a screening test to identify diseases with longer latency periods, so longer length time bias. This bias due to non-rambling sampling of the study subjects is known as selection bias. Bias when the subjects are not treated equally is known as procedure bias, right? Okay, so we have done a quick review that for case control study, the bias that needs to be addressed is the recall bias. Question number 64. A group of researchers is comparing the efficacy of conservative to operative management of acute appendicitis. So we have 500 patients randomly assigned to one of the two groups, 250 in each group, right? 250 are going to get conservative management, 250 are going to be operated, and then they are being followed for a period of 2 years. Which of the following describes the study design? So we have people both have like the disease, right? So of course, like everyone is going to have appendicitis, but the difference is the treatment. Some are going to get the treatment and some are just going to be managed conservatively and not be operated. So whenever there is an intervention involved, this is known as C, randomized control trial, right? Assigning patients to one of or two of the group of interventions, that is treatment versus placebo, and then comparing the outcomes is known as a randomized control trial. And what is the study that is done to determine the prevalence? That is known as cross-sectional study. What is the study done to determine the odds ratio? That is the odds of exposure amongst the affected group divided by the odds of exposure amongst the non-diseased or non-affective group is known as case control, in which they have already developed the disease, but we are just finding the odds of exposure, right? And we already know that both prospective and retrospective cohort studies can be done, and in them we just find the relative risk. And how do we find the relative risk? We find the relative risk of developing the disease in those who are exposed versus unexposed. And in this case, of course, like they were receiving interventions, so interventions basically means randomized control trial. Whenever we are having an intervention, conservative management versus operative management for acute appendicitis, and then we are going to follow them, which basically means an intervention, and then we are going to follow them for results. This is known as an RCT, and a cross-sectional study is used to measure the prevalence. Question number 65. We are going to, a study is done to assess the blood pressure differences between the residents of different states. Again, they didn't state how many number of states, so it's quite possible it's greater than 2, right? And we are just going to calculate the mean blood pressures of the residents. Again, the blood pressures of the residents can be in a range 100, 110, 120, 120, 130, right? So there's a complete range. So when there's a complete range and then their means are compared for greater than 2, then the test would be B, ANOVA test. But if they said we are just going to compare 2 states like California and Georgia, then in that situation it would be, the answer would be a t-test, right? And of course we are using the means, we are not using categorical values. If we use just 2 categorical values, that would be Fisher's extract. If we use greater than 2, that would be chi-square, right? So we are not going to revise all of this because we have seen this previously. And the difference between percentages or proportions of categorical outcomes: hypertensive, non-hypertensive, diabetic, non-diabetic, in just greater than 2 number of people, 2 number of groups is chi-square, whereas Fisher's extract is just 2 groups, and then we are going to compare the categorical outcomes like blood pressure, no blood pressure, diabetes, no diabetes. Okay, question number 66. We have a 54-year-old female, and she is coming to the office to discuss preventive care. Mammo is recommended for her, and she wants to learn why mammo is a good choice for her, right? So what makes a screening test a good test, right? So we have the remember from our previous discussion, we remembered with N, that N for screening and N for the sensitivity N and N for the false negative rate. And then we gave the value that a good screening test will be highly sensitive and will have low false negative rate. Therefore, the correct answer over here is B. Whereas if they said that the patient is concerned about biopsy for her breast lump, right? And biopsy is the confirmatory test, and then she is questioning that what makes it a good test, good confirmatory test. Then with the C we would have gone with the specificity and the false positive rate. So we would say that for a good confirmatory test, it has high specificity and it has a low false positive rate. And you know, the idea behind screening is that we want to screen and get in all the people who might be affected by the condition, and we are not concerned about the false positives, because the false positives are actually going to be eliminated by the other test. So you can also say that it has a high false positive rate, right? Because you are not concerned with false positive, we just want to eliminate the false negatives. And then of course when we are going to confirm, then we are going to exclude all the false positives. And how they close the results are to each other, this is known as precision. And the impact of intervention or exposure in cohort studies, right? Whenever we have an intervention or exposure in cohort studies and we want to find the impact, that is known as number needed to treat. Whereas if the impact, we want to find the adverse effect impact of intervention or exposure, then this is known as the number needed to harm. And here we have it that whenever we have a good screening test, the good screening test should have high sensitivity and low false negative rates, and false positives are absolutely okay because they will be eliminated by the confirmatory test. And our goal is to identify a maximum number of people with disease and not to miss anyone. Whereas if we want to find the impact of an intervention, especially in cohort studies, that is going to be calculated by the number needed to treat. We have a retrospective cohort, and in this we have to assess the relationship between long-term ibuprofen use and stomach cancer development. The relative risk was calculated as 1.05 and the confidence interval 0.99 to 1.08. Whenever you hear the word confidence interval, find out immediately whether it has the value of 1 or not. If it has the value of 1, no significant association exists, and it means that there is no correlation, right? So the correct answer over here is that it cannot be concluded that long-term ibuprofen is associated with stomach cancer development. Why? Because the confidence interval has the value of 1 and the relative risk is also basically equal to 1. It was greater than 1 and the confidence interval did not have the value of 1, then we would say that it is strongly associated and it is an increased risk factor. If it was less than 1 and confidence interval did not have the value of 1, then we will say that it is associated with decreased risk. So no association between long-term ibuprofen use and stomach cancer. How? When the relative risk is 1, right? So relative risk, whenever the confidence interval has the value of 1, it makes the result statistically insignificant. Whereas if the relative risk value is greater than 1, it means that there is increased risk or increased incidence. If the value is less than 1, it basically means the opposite, that is, it is protective and there is decreased risk, right? And whenever, of course, the confidence interval has in its entirety, for these conclusions to be reached, confidence interval should not have the value of 1. If the confidence interval does not have the value of 1, then it is statistically significant. So if the relative risk is 1, it means that there is less per 5% chance of there being no significant association. Okay. We have a clinical study in which we are going to study the response of a novel calcium channel blocker in people with essential hypertension, and that drug is compared to amlodipine, and we are going to find, it was found that it averagely reduced the blood pressure by 2.3 millimeters of mercury. So the new drug is decreasing the blood pressure by 2.3, and we have a 95% confidence interval of 0.9 to 2.6, right? And despite these findings, the drug does not replace amlodipine, which amlodipine is still the preferred treatment. Why did the drug not replace amlodipine till now? Okay, there is one very important concept that you have to understand over here, that there are two types of confidence interval values that you have to look for. There is one type of confidence interval value in which confidence interval should not contain the value of 1, and there are another type of studies in which confidence interval should not contain the value of 0. Right? So you have to understand this concept very carefully. Whenever we are comparing two drugs in such a way that we have to subtract the difference in the observed values, then we use the value of 0. Right? For example, this drug also causes 3 millimeter mercury difference in decrease in blood pressure, and this drug also causes a 3 millimeter mercury decrease in blood pressure. And when we subtract the two, we find that 0. There is no difference between the two drugs. Amlodipine and the new drug are absolutely the same. So whenever we have to just for example, this value in which we are comparing the blood pressure findings, in this situation we have to subtract or find the difference. Whenever we have to subtract or find the difference, then we use the value of 0 as the nullifier for the confidence interval. If the value of 0 is present, then it will make the confidence interval statistically insignificant. Whereas, as we just did in the previous one, where we were calculating the risks, such as the risk of cancer development by drug A versus risk of cancer development by thing B, right? With ibuprofen, risk of cancer development, or with a new drug, the risk of cancer development. Then these risks were actually divided by each other, right? And when we were actually dividing the risk, then the value comes out to be 1. If the value is 1, that means that the risks are not significant, okay? So you have to separate these two concepts, that whenever there is a difference such as blood pressure values, then we have to consider that confidence interval should not contain the value of 0. Whereas whenever you are comparing the risks between ibuprofen use and no ibuprofen use, then the confidence interval should not contain the value of 1, because when and we divide the two, and the risk is 3 and the risk at the bottom is 3, both can cancel out and the value comes 1, right? So for here, you have to consider that the confidence interval should not contain value of 0. So does it have the value of 0? No, it doesn't have the value of 0, which means it is statistically significant, right? But is the results clinically significant? Even though it's statistically significant, 2.3, like from a value of 140, if you just decrease it to 138, it's not clinically significant, right? So the correct answer is B. The results are statistically significant. Yes, they don't have the value of 0 that can nullify the confidence interval, but they are but they are not clinically significant. The 2.3 millimeters of mercury value is not clinically significant. And let's discuss this. Let's do a quick review of this, I think, at the end, where I made these notes that whenever, like, we are going to do a study drug and that decreases the blood pressure by 2.3 millimeters of mercury as compared to the amlodipine, and this is the 95% confidence interval that does not have the value of 0. Right? Whenever we are taking differences, it should not have the value of 0. Whenever we are comparing the ratios, such as the risk of development of cancer with ibuprofen versus no ibuprofen use, then we will say that the confidence interval should not have the value of 1. Whereas the values of blood pressure are given where we do a subtraction or difference, then 0 should not be present. Right? So in this situation, we already found out that 2.3 millimeters of mercury is not clinically significant, but the results are statistically significant because this range, 0.9 to 2.6, does not have the value of 0. Okay? So I hope this was clear. So question number 69. If there is a 75-year-old female smoker, she has significant family history of lung cancer. And there's a 25-year-old female smoker who has no family history of lung cancer. She is patient B. And they both undergo CT scans. Which of the following best represents the comparison for using the test for diagnosing lung cancer in the two patients? So, basically, when they are giving us that this patient is old and has significant history of prevalence of lung cancer in the family, that means that she has increased prevalence because of her age and her family history. Whereas this patient is young and has no family history, then this is telling us that this patient is less likely and has less prevalence. So out of these values that they have given us, which of these is actually affected by the prevalence? You automatically know that the positive predictive value is higher for patient A, or it can also be said as that the negative predictive value is less for patient A. Remember that prevalence is directly proportional to positive predictive value. So if the prevalence is high, positive predictive value goes up. Whereas if the prevalence is high, the negative predictive value goes down. So they could have said that the positive predictive value is higher for the patient A, or they can say that the negative predictive value is lower for the patient A, and then vice versa. So you just have to know that which are the integral features of the diagnostic test and do not depend on the external variables. They are sensitivity and specificity. And sensitivity is how likely a person is affected by a condition test positive. The person already has the disease. Remember the mnemonic SEND? The person already has the disease. How likely is it that he will test actually positive? Whereas specificity, remember the mnemonic PH? The person is already healthy, and what are the chances that he will test negative? This is specificity. Whereas positive and negative predictive values basically mean that the person tested positive and the person tested negative, how likely it is that the positive person has the disease and negative person doesn't have the disease. And this depends on external variables such as prevalence, and I told you that PPV is directly proportional to prevalence, whereas NPV is inversely proportional to prevalence. Okay, so where were we? I think we were over here, that two people who were actually like being affected. What's the question number? Let's look at the question number. Okay, that's 69. Let's see if we have like 69, and then okay, maybe we'll find it like later on. Okay, yeah, 75 female. Right here, 75 female, and then who has family history of breast cancer. 25 female, no history of breast cancer. Both have done CT scan. What's the difference? Difference can be of PPV because it is dependent on the prevalence, right? So the patient who is 75 female and has a positive family history basically has greater PPV. And what is not affected by the prevalence? Specificity and sensitivity. Question number 70. A group of researchers is trying to assess the relationship between exposure to secondhand tobacco and abdominal aortic aneurysm development. The ultimate goal is to determine the relative risk of abdominal aortic aneurysm development in people exposed to significant amounts of secondhand smoke, and then they are going to compare it to the unexposed. They want to present the results at a conference in 6 months. That's the keyword, that okay, they only have a limited amount of time. What's the type of study that's going to help them get in the results in a significant amount of time and establish the relationship between the exposure and the disease development? Okay, so cross-sectional study is basically not a relationship study, it's just a prevalence study. It will not tell us the relationship between the exposure and the disease. Okay, so we remove it. Case control study is when we already have the people who have developed the disease, right? So where are we going to find all these people, and how are we going to follow them in such a short period of time? So okay, that is probably not possible. So the correct answer over here is a retrospective cohort study, that we can take the people from the past, from the past. Instead of following them in the future, we can go back in point in time and look at the case records, and from the case records we can find out that who are the people, the people who are exposed and the people who are unexposed, and then we can follow that who actually developed the abdominal aortic aneurysm, since a cohort study begins with the risk factor, and then from the risk factor the people develop the disease. Some develop the disease and some don't develop the disease. So this is a cohort, so we can follow them from a retrospective cohort. So this is the advantage of retrospective cohort. If you're short of time and you need to establish association between the risk factor and disease, do a retrospective cohort. Whereas a prospective cohort, of course, if you take smokers and non-smokers today and then follow them, it's going to be a long time till they develop abdominal aortic aneurysm. And of course, clinical trials also take a long time and they require an active intervention. So in this situation, you can't to give an active intervention, you can't actually expose some people to smoke, right? Secondhand smoke, that would be unethical. And case control studies actually find the odds of exposure in affected versus unaffected. And cross-sectional studies basically determine the disease frequency of the disease, as well as the risk factor. Cohort studies actually study the risk of developing a condition based on exposure to a risk factor. So they wanted to, on the basis of exposure or no exposure to secondhand smoke, so they were starting with the risk factor if they wanted to follow for the disease. It's not like they had the abdominal aortic aneurysm patients as well as the controls and then they wanted to go back and look at the risk factor, then that would be the case control study. But over here they want to see the effect of exposure to smoke, no exposure to smoke, and then they want to see who developed the disease. So the most time efficient way would be to actually do a retrospective cohort. So if we want to find out that the relative risk of abdominal aortic aneurysm in people who have been smokers and some who have not been smokers, and they want to present the result in 6 months, so they basically will have to do a retrospective cohort. Whereas if you want to find the frequency of disease and the risk factor, or just the prevalence of the disease, then this will be a cross-sectional study. So this concludes our part 2 of Biostat review. If you like this video, please like, share and subscribe and follow for more, and we will be back with the part 3 of Biostat review. And thanks for watching and happy studying.